I'm Dr. Ashish Garg, Assistant Professor Cardiology, and I will be discussing echo assessment of diastolic function as part of the CC program. The outline of my talk will include introduction to diastolic function, determinants, basic echo and Doppler parameters of diastolic function, grading of diastolic dysfunction, the guidelines and additional parameters of diastolic function, diastolic stress test and assessment in special populations. So diastole means to expand, and normal LV diastolic function is clinically defined as the capacity of the left ventricle to receive a LV filling volume that guarantees an adequate stroke volume operating at a low pressure. So diastole can be divided into 4 phases, that is isovolumetric relaxation, the early rapid diastolic filling, diastasis where minimal filling happens, minimal to no filling, and late diastolic filling, which is caused by atrial contraction or the atrial kick as we call it. The LA functions as a reservoir during systole, as a conduit during early diastole, and a pump during late diastole. So an important parameter to understand is the isovolumetric relaxation time, which starts with the aortic valve closure. So as the aortic valve closes, there's a rapid decline in LV pressure. This phase is an active phase, and when the LV pressure falls below the LA pressure, the mitral valve opens. So this is the isovolumetric relaxation time, and it is 100 plus minus 10 milliseconds in normal individuals. The second important phase is the rapid early diastolic filling, in which the rate of LA to LV flow is determined by the pressure difference, the ventricular relaxation, and the relative compliance of the two chambers. During diastasis, as I mentioned earlier, there is little to no flow, and the duration is dependent on the heart rate. It is entirely absent at faster heart rates. The important late diastolic filling phase is due to the atrial contraction, is responsible for 20 to 30% of the total filling, and this is an important contribution which is lost in conditions like atrial fibrillation. So the diastolic function, it depends on the chamber compliance, the filling pressures, and the elastic recoil of the ventricle, and the effect of the pericardial constraint. If there is abnormal relaxation of the ventricle, there is prolonged isovolumic relaxation time. There is a reduced early peak filling rate. So the measures of LV relaxation are IVRT, dP by dt, which is the maximum rate of pressure decline, and tau, time constant of relaxation, which is an invasively measured parameter and is an important parameter to assess diastolic function, tau or the time constant. As I mentioned earlier, IVRT is the time interval between the aortic valve closure and the mitral valve opening, and it provides an insight into the rate of early diastolic LV relaxation. If the relaxation is prolonged, the mitral valve opening is delayed and the IVRT is increased. Isovolumetric pressure decay is another measure, which is the rate of pressure fall, that is dP by dt, and it is afterload dependent. If there is an increase in dP by dt, it signifies an increase in myocardial relaxation. So HFpEF patients have larger dP by dt. The time constant of ventricular relaxation, or tau, the normal tau is around 34 milliseconds. It is measured invasively, and it describes the rate of LV pressure decline throughout isovolumetric relaxation. As we can see in this graph, the normal tau is around 34 milliseconds, and if there is diastolic dysfunction, the tau increases, which means that it takes longer for the LV pressure to fall and there is more impaired relaxation. Compliance is the ratio of change in volume to change in pressure, and stiffness is the inverse of compliance. So while ventricular diastolic function is a major factor affecting diastolic filling, these two concepts are not identical. Peak early diastolic filling rate is affected by changes in preload that affect the initial pressure difference between the ventricle and the atrium. This is increased with volume loading and decreased with volume depletion. change in transmitral volume flow rate, that is increase with coexisting MR, and change in atrial pressure, that is due to elevated LVDP or a V wave caused by MR. The late diastolic filling rate is affected by atrial contractile function, the timing of atrial contractile function, the ventricular end diastolic pressure, and the ventricular diastolic function. So we can see that the atrial filling patterns are reflected well in the JVP, and also in the pulmonary and the hepatic vein patterns, which appear opposite in direction. The LA filling does not increase with inspiration because the pulmonary venous return is entirely intrathoracic, and it is thus not affected significantly by respiratory changes in intrathoracic pressure. However, on the right side with inspiration, there is negative intrapleural pressure and there is increased venous return to thorax, causing an increase in the RA volume and causes an increase in the RV diastolic filling. But this doesn't hold true for the left-sided filling. So coming to echo assessment of LV diastolic function, the four important basic indices are the mitral inflow, the tissue Doppler mitral annular velocity, the left atrial volume index or LAVI, and the TR velocity. And the other indices are pulmonary venous return, color M mode flow propagation velocity, IVRT, and the Valsalva maneuver.
Yeah.
So how do we check the mitral inflow? We keep the sample volume at the mitral leaflet tips and a sweep speed of 50 millimeters per second for evaluation of respiratory variation of flow velocities. So as we can see in this diagram, you keep the sample volume at the mitral valve leaflet tips, and this is the E wave and the A wave that you get. And this pattern is suggestive of a normal filling where the E wave is more than the A wave in amplitude. The mitral E velocity reflects the LA-LV pressure gradient in early diastole. The A velocity reflects the LA-LV pressure gradient during late diastole, and it is affected by LV compliance and the LA contractile function or the atrial kick. The E wave deceleration time is influenced by the LV compliance and the LV diastolic pressures following mitral valve opening. So we can see this is the E wave and the A wave, and the E wave reflects the early diastole, the LA-LV pressure gradient during early diastole, and the A wave reflects the LA-LV pressure gradient during late diastole. Sinus tachycardia and first degree AV block tend to fuse the E and A waves, and atrial fibrillation eliminates the A wave. This is important to know because the interpretation would then change and we would have to rely on other parameters like E by E dash, which we will be discussing in a short while. The L velocity is seen in patients with left ventricular hypertrophy or hypertrophic cardiomyopathy and is specific for elevated LV filling pressures. And this allows us to identify elevated LV filling pressure in the context of a delayed LV relaxation in these two conditions. There is HCM and if there is significant LVH. This is the L wave which occurs in mid diastole. The deceleration time is inversely proportional to chamber stiffness. So more the chamber stiffness, less will be the deceleration time. And another parameter is the A wave duration. So deceleration time is measured from the peak of the E wave to the baseline. So coming to the next parameter, that is the tissue Doppler mitral annular velocity. We keep the sample volume on the annulus near the mitral valve insertion and both the septal as well at the septal and the lateral annulus, and measure the E prime velocity, which we can see. So the peak annular velocity in early diastole, that is the E prime, it depends on LV relaxation, and in normal diastolic function, the E prime increases with higher filling pressure. The E by E prime ratio is an important ratio which predicts filling pressure in the setting of abnormal diastolic function. It is predictive of adverse events in acute MI, hypertensive heart disease, end-stage renal disease, AF, cardiomyopathy, and it is one of the most reproducible echocardiographic parameters to estimate the capillary wedge pressure, and is the preferred prognostic parameter in many cardiac conditions. The normal E by E prime is less than 10. So as the LV filling pressure increases, the E prime decreases, the mitral E velocity, that is the early diastolic filling wave, increases, and the E by E dash increases. And increase in E by E dash is predictive of elevated filling pressures or an elevated pulmonary capillary wedge pressure. So this is an important concept to know, that E by E prime is an elevated E by E prime is predictive of elevated pulmonary capillary wedge pressure or LV filling pressure. And you need to know this because these patients may develop pulmonary congestion, pulmonary edema, if not adequately diuresed. So again, this slide is reflecting the same, that when the E by E dash is more than 15, the LV filling pressure is elevated, more than 15. Coming to the LA volume index, basically what we need to know is that if there is diastolic dysfunction, the LA volume will increase, and it is a good marker of chronicity of the condition. So there are two approaches to do this, the Simpson method and the area length method, and you measure the LA volume keeping the mitral annulus as the inferior border. You exclude the pulmonary veins and the LA appendage to measure the LA volume. Normal left atrial volume index is 16 to 28 ml per meter square. You must correct the volume to the body surface area and report it as ml per meter square. This is the formula for left atrial volume. So as there is increase in the grade of diastolic dysfunction, there is an increase in the left atrial volume index, and this graph represents the same. So impaired LV relaxation is associated with a reduction in the LA conduit volume and a lower diastolic AV gradient. The reservoir pump complex is enhanced to maintain optimal LV end diastolic volume and normal stroke volume, and with a more advanced degree of diastolic dysfunction and reduced LA contractility, the LA contribution to LA filling decreases. However, the left atrium may also be dilated in the absence of diastolic dysfunction in patients with flutter, fibrillation, significant mitral valve disease like mitral stenosis, anemia and high output states, and in athletes. So this needs to be kept in mind, that dilated LA may also be seen in the absence of diastolic dysfunction, as mentioned. So diastolic dysfunction is mostly seen in elderly patients and is present in more than 25% of adults more than 40 years of age. The chances of a patient having diastolic dysfunction increase with aging because there is myocardial stiffness. However, it is also seen in patients with systolic LV dysfunction, and it is seen in more than 50% of heart failure cases. So coming to the grading of diastolic dysfunction, there is 1, 2 and 3 grades. One is impaired relaxation. These patients have delayed LV early relaxation but a normal LA pressure, and are usually asymptomatic at rest, may have dyspnea with exertion. Grade 2 is the pseudo-normalization, where there is mildly elevated LA pressure, and these patients may have mild symptoms. Exertional dyspnea is common. In restrictive filling, the LV is non-compliant, there is increased stiffness, and there is a high opening LA-LV pressure gradient. So these patients have moderate to severe symptoms, may have HFpEF or heart failure with reduced ejection fraction, and have high LV filling, and may or may not respond to diuresis. So this diagram beautifully depicts the changes in the mitral Doppler velocities with the increasing grades of diastolic dysfunction. This is a normal trace, and this we can see that the E wave is less than the A wave. So this is stage 1 or impaired relaxation. Pseudonormal is called pseudonormal because it, as you can see, the E wave amplitude increases and it almost resembles the normal tracing. However, you can differentiate between normal and the pseudonormal stage by making the patient undergo a Valsalva, or you can look at the tissue Doppler velocities to differentiate between normal and the pseudonormal stage. And in the restrictive stage, the velocity, the E wave amplitude increases markedly in comparison to the A wave amplitude. The E prime velocity also decreases with increasing grade of diastolic dysfunction. So this is what we should broadly remember, that E by A velocity, it will increase with increasing grades of diastolic dysfunction, and the E prime will reduce. So this flow chart, it shows us that when there is an E by A of more than 2, there is a decreased deceleration time less than 150 milliseconds, which indicates an advanced degree of diastolic dysfunction. It is suggestive of increased left atrial pressure. If the E by A velocity is less than 1 and the E by A velocity is less than 1, it may be normal LA pressure, and the E by E prime more than 15 is also suggestive of an increased LA pressure. The left atrial volume index more than 34 ml per meter square, the E by E prime more than 15, all these are suggestive of diastolic dysfunction and increased left atrial pressure. So you measure the septal and the lateral E primes, the LA volume. If the LA volume is increased more than 34 ml per meter square, that goes in favor of diastolic dysfunction. The E by A ratio more than 2, the deceleration time is less than 150. If all these are suggestive of a grade 3 diastolic dysfunction. And if the septal E prime is more than 8, the lateral E prime more than 10, the LA volume index less than 34, you can be sure that there is normal diastolic function. So in patients with normal ejection fraction, you measure the septal E prime, the lateral E prime more than 7, more than 10, and average E by E dash less than 14, TR velocity less than 2.8, LA volume index less than 34. If 3 or more than 3 are normal, it is suggestive of normal diastolic function. If they are around 2, it may be grade 1 or 2 diastolic dysfunction. If it is more than 3, there is advanced diastolic dysfunction. These 4 parameters are very important. That is the septal and the lateral E prime velocity, the E by E prime, the TR velocity, and the LA volume index. And we must measure these 4 whenever trying to grade diastolic dysfunction in any patient. I'll repeat again, the E prime, the E by E dash, the TR velocity, and the LA volume index. This flow chart depicts the same that we have already discussed. E by A more than 2 is suggestive of a grade 3 diastolic dysfunction. You measure the E by A. If it is more than 0.8 and the E by E prime is less than 10, it is suggestive of a normal diastolic function. And then you look at the other parameters, the E by E prime, the TR velocity. If it is more than 2.8, LAVI more than 34. If there is 2 positive, then you can be sure that there is diastolic dysfunction. If 2 out of 3 are negative, then probably it is grade 1 diastolic dysfunction or normal diastolic function. So the point here is that one parameter cannot be used to assess or grade diastolic dysfunction in isolation. It always, like whenever in all conditions where you use the echocardiography, you need to look at all the parameters and then come to a conclusion if the patient has diastolic dysfunction or not. Many a times you will see that the patient may have an E by E prime more than 14, but E by A around 1 or 1.2, and then so you look at the TR velocity, the LA volume index, and other parameters to correctly grade the diastolic function. This we have already covered. So coming to another parameter is the pulmonary venous flow pattern, in which the sample volume is kept within the RUPV or the LUPV, and you can see that there is a systolic wave and a diastolic wave, and usually in the pulmonary venous flow, the systolic wave is more than the diastolic wave in amplitude. The SD ratio is the most commonly reported value and the ratio of the peak antegrade velocity in systole and diastole, and normally the systolic velocity is more than the diastolic velocity. So the AR by A duration is shown to correlate with LVDP, and as the left atrial pressure rises, the AR duration lengthens and AR by A difference increases. It is the most sensitive and earliest indicator of elevated left atrial pressure, and more than 30 milliseconds indicates elevated LVDP. It is accurate in MR and HCM patients. Young normal subjects have a predominant diastolic wave, and with increasing age, the SD ratio increases. As the LA compliance decreases, the SD ratio decreases, and the systolic fraction becomes less than 40%. And the S wave velocity duration, the S wave amplitude decreases, and the diastolic amplitude increases. The color M mode flow propagation velocity, it measures the slope of the early diastolic valve to apex contour, and in impaired relaxation there will be a reduced slope of the line, as we can see here. Normally it is more than 50 centimeters per second. Like I mentioned earlier, the M mode flow propagation velocity should never be used in isolation. IVRT is the sample volume. You keep the sample volume between the aortic valve and the mitral valve, and you simultaneously display the end of aortic ejection and onset of mitral inflow. This is the end of aortic ejection and the onset of mitral inflow. And the normal IVRT is less than 70 milliseconds. We can see it here also. This is the end of aortic ejection and the onset of mitral inflow, and the duration between these 2 points is the IVRT. Valsalva maneuver is used when there is a pseudo-normal kind of pattern, and what we do is we make the patient perform a forced expiration for 10 seconds with the mouth and nose closed. In normal subjects, there will be reduction in both the E and A velocity to a similar degree, and the E by A ratio is unchanged. If there is a decrease in the E by ratio of more than 50%, it indicates elevated filling pressure. This image beautifully depicts how the Valsalva maneuver can be used to differentiate a pseudo-normal pattern with a normal pattern. Excuse me. This patient had has a normal kind of a E by A pattern, and when you make the patient perform the Valsalva, there is a decrease in E velocity and a decrease in E by A ratio. So this indicates diastolic dysfunction. There are other parameters like some deformation indices like LV strain rate or the untwisting rate or the LS systolic strain rate. Coming to the table and trying to summarize what all we have discussed till now. So there are 3 stages: the stage 1, which is the impaired relaxation, the stage 2, which is the pseudo-normal stage, and the stage 3, which is the restrictive filling. So IVRT normally is less than 70 milliseconds, and when there is impaired relaxation, it increases. However, in the stage 2, it again becomes normal. The E by A ratio is unitless, and it is normally between 0.8 to 1.5. When there is stage 1 or impaired relaxation, the E by A ratio becomes less than 0.8. In stage 2 pseudo-normal, it is between 0.8 to 1.5, and when there is restrictive filling, it is more than 2. Valsalva is important to differentiate stage 2 from the normal, and when you make a patient with stage 2 perform a Valsalva maneuver, the ratio reverses. The normal deceleration time is 140 to 240 milliseconds, and it shortens markedly in stage 3 diastolic dysfunction, lengthens when there is stage 1 impaired relaxation. The normal E prime, that is the tissue Doppler velocity at the septum, is more than 10 centimeters per second, and laterally it is more than 12 centimeters per second. With advanced diastolic dysfunction, it decreases to less than 5 centimeters per second and less than 8 centimeters per second for the lateral E prime. And the E by E prime ratio, it is less than 8 normally, and when there is restrictive filling, it is more than 14. For the pulmonary venous flow, we can see that the systolic wave amplitude decreases markedly as compared to the diastolic wave, which is, and in normal subjects, the systolic wave is always more than the diastolic wave. The propagation velocity slope is more than 50 centimeters per second in patients with normal diastolic function, and it decreases when even with the stage 1. The LA volume index, it is more than 34 ml per meter square in stage 3, and normal value is between 16 to 28 ml per meter square. So this is a very, very important table, and this will help you in day-to-day clinical practice when you're trying to assess echocardiographic, when you're trying to assess diastolic function echocardiographically, and we must try to remember this table and use as many parameters as we can to come to a conclusion. This is a schematic showing the same, and we will not be discussing this here. So diastolic stress test, it is used when the resting echo is not able to explain the symptoms of heart failure, especially with exertion, and it helps us to evaluate filling pressure in patients with known diastolic function with mild symptoms. What happens is that when you make the pressure, when you make the patient exert, the LV filling pressure increases, and that you can pick up with a diastolic stress test. You can use a supine bike, or you can use a bike or a treadmill to give for exercise stress. And at rest, the mitral E and annular E prime velocities are recorded along with the peak velocity of the TR jet, and the same parameters are then recorded during the exercise or 2 minutes after termination of exercise, when E and A velocities are not merged, because E and A velocities may merge when the patient develops sinus tachycardia. So the test is considered positive when the average E by E prime is more than 14, when the peak TR velocity is more than 2.8 meters per second, or the septal E prime velocity decreases. So this was a patient, and we can see that the TR velocity has increased to approximately 3.5, and the E prime velocities, so mainly the TR velocity has increased here in this case. In atrial fibrillation, the peak TR velocity more than 2.8 meters per second is suggestive of elevated left atrial pressure, an IVRT of less than 65 milliseconds, and a deceleration time of pulmonary venous diastolic velocity suggestive of abnormal diastolic function. In sinus tachycardia, E by E prime is a reliable index and should be used to assess diastolic function, because the E and A velocities are fused when the patient has sinus tachycardia. IVRT is also a specific indicator of diastolic function. In atrioventricular, in first degree AV block, again the same problem, that there is fusion of the E and A velocities, and the E and A velocities can only be used when there is no fusion. So you use the E by E prime ratio in these patients. In HCM, E by E prime is a reliable index, the LA volume is a reliable index, and the TR peak velocity more than 2.8 meters per second. The most important here is the E by E prime, which helps us to determine if the patient has diastolic dysfunction or not. In restrictive cardiomyopathy, IVRT and E by E prime are reliable indicators. Thank you.